So our first speaker of this morning is Dr. Matthias Maiwald from Singapore. Dr. Maiwald is a senior consultant of microbiology and the head of service at the KK Women's and Children's Hospital, and is an Adjunct Associate Professor at the Department of Microbiology and Senior Consultant in Microbiology at the National University of Singapore and at Duke National University of Singapore Graduate Medical School. So Dr. Maiwald will present on Singapore from the front lines. Thank you.
Okay, thank you very much, Kevin, for the wonderful introduction. Thank you, everyone, for having me and for having me speak to you. I will get right into the matter and report about the Singapore experience in the outbreak. And part of that has a history, which is that Singapore was hit quite badly by the 2003 SARS outbreak. If you look on the left of the slide, you see that Singapore was among the worst affected countries with 238 cases and 33 deaths. And that included also 5 deaths among healthcare workers. And Singapore took a very painful lesson from that. And the lesson was, due to Singapore's exposed location as a travel and trade hub, it is extremely vulnerable to imported infections. And there has been a big sense of insecurity in Singapore since that 2003 outbreak. Since that outbreak, Singapore kept doing pandemic planning. And what this slide shows you is our hospital's emerging infectious disease page. In fact, from 2015, when MERS coronavirus, Ebola and influenza A, H7N9 and avian type of flu were around. And what you see here is various pandemic preparedness plans, what to do when scenario. So a patient comes in from where, and then you treat the patient or triage the patient in a certain way. So that was way before the current coronavirus outbreak. This slide shows you the screening procedures that the hospital had in place from 2015. And what happened was that any patient coming into the hospital was screened and triaged as to whether they had traveled to one of the affected areas. And then they were asked relevant questions according to a questionnaire. And then if they were coming from one of the affected countries, they were led to an isolation room immediately and treated accordingly and then admitted accordingly. This slide shows you the so-called exercise Sparrowhawk 1 and 2, which is that during the years, Singapore did various exercises, and basically the exercises consisted of a mock patient with a simulated infection arriving at the hospital. It involved a role play, and it was conducted for Ebola in 2015 with enhanced PPE and respirators, which you see on the bottom left photograph, and then subsequently for respiratory X disease with full PPE, with N95 masks, eye protection gowns and gloves. Similarly, in the years leading up to the current coronavirus outbreak, Singapore built a National Center for Infectious Diseases, NCID, which is a purpose-built medical facility that is organized within the public healthcare system. That NCID has about 17 wards, 330 beds and 2 ICUs, and it has a high-level isolation ward that is capable of handling Ebola, Marburg and anthrax. It also has research and diagnostic facilities, and it houses the National Public Health Laboratory, abbreviated NPHL. It was formally opened on 7th September 2019, which is obviously very incidental, but it was just in time to be able to be put in service in the current coronavirus outbreak. This one here is KK Women's and Children's Hospital on this slide, which is my workplace. It is an 830-bed pediatric and obstetric and gynae hospital, a tertiary level academic teaching hospital for National University of Singapore and Duke NUS, This is my workplace, and I'm a clinical microbiologist at the hospital's Department of Pathology and Laboratory Medicine. We have a relatively small microbiology section, so the listeners shouldn't expect big wonders or big deeds from our department. So we are a relatively small department. And in this coronavirus outbreak, we have obviously been struggling with the outbreak and how to do the laboratory testing. This one here is a newspaper article from the local newspaper, the Straits Times, on 4th January 2020, in which the article already warned about a mystery pneumonia in a Chinese city, which was Wuhan. And at that time, a couple of days earlier, actually, the news had just gotten out that there were such cases in Wuhan emerging. This slide here shows you the so-called Wuhan exodus. And on the left, we have an article from the New York Times, which summarizes the issue quite nicely. And on the right corner, you have an article from Emerging Infectious Diseases. And so effectively what happened was Wuhan went into lockdown by the Chinese government on the 23rd of January 2020. And apparently it is alleged that about 5 million people left Wuhan before that lockdown. And it was just before the Chinese New Year, which was this year quite early on the 25th and 26th of January 2020. And this is in fact the biggest yearly travel period in China. So there was travel inside China, of course, people visiting their relatives, but there was also travel to the surrounding countries, Thailand, Singapore, Bali, Hong Kong, Taiwan, Japan, and South Korea. And this constituted the so-called first wave of people leaving China and bringing the virus outside China. This slide here shows you the laboratory testing page of the World Health Organization. And early PCR assays became available in January 2020. So there was the DORSCON assay from Berlin in Germany, which Kevin already mentioned. There was another one from Hong Kong. There was another one from China CDC, another one from the Department of Medical Sciences in Thailand, and another one from the National Institute of Infectious Diseases in Japan. And if you look at the timeline on the top right, you can see that the Berlin assay from Germany was available on the 13th of January, which was 2 days after the sequence became publicly available of the novel coronavirus. This next slide here shows you the early developments of the pandemic. So on 23rd of January, Singapore confirmed the first case of the, at that time called Wuhan virus, and that was in a traveler coming from Wuhan, China. Then on the 25th January 2020, the numbers had already increased. There were over 800 cases in China, with 26 deaths in China, and a few countries surrounding China had their first cases. And if you look on the right, on the 7th of February, the outbreak had spread further, over 30,000 cases in China, with over 600 deaths, and the number of affected countries had risen. So in this slide, we're talking about the adoption of testing in Singapore. Among the first ones to start in Singapore was the National Public Health Laboratory, NPHL. It designed its own PCR from the N gene and the OF1AB gene, and the assay was later published in JAMA, alongside with some Singapore epidemiology. Then Singapore General Hospital is a big local hospital with a department of molecular pathology. It adopted the German assay in late January, and then other hospital labs, public and private labs, followed suit. And we received panels of coded samples from NPHL. We had to test them blindly, and when they were all correctly tested, we got an approval for testing by the Ministry of Health. And we at our hospital, we started testing on the 11th of February. And subsequently, in the ensuing weeks and months, commercial PCR kits became available. For example, the Tipmolbiol kit from Berlin in Germany, or there was a Fortitude kit, which is a Singapore homegrown kit. Then the big companies came in with Roche and their testing kits. And we at our hospital had to ramp our testing capacity to about 500 a day, which is fairly big testing capacity for our relatively small lab. And some bigger labs took on testing capacities of 1,500 to 2,000 per day. Then subsequently, serology became available for the coronavirus, and it started at KK Hospital on an Abbott platform on the 22nd of May. And Singapore, with a population of 6.6 million, aims at a test capacity of about 40,000 PCRs per day. This slide shows you the biosafety implications for testing. So with the testing rolled out, we needed to develop protocols on how to do this safely. And of course, there are two distinct kinds of laboratory areas, which is one, the microbiology lab and the molecular microbiology lab. And then second, the other clinical laboratories such as hematology, clinical chemistry laboratory, and so on. Yeah. And we distinguished in respiratory type specimens, which posed a higher risk, or non-respiratory type specimens, such as blood or urine, which posed a lower risk. So what you see here in the red picture is a double-bagged specimen which had to be labeled and double-bagged before being sent to our lab for every specimen from a coronavirus suspect patient. For the respiratory type specimens, we implemented specimen processing under biosafety cabinets with people wearing goggles, N95 masks, gowns and gloves for specimen processing. And we deliberately excluded pregnant women and staff on immunosuppressant medication from having to process these specimens. On the right of the slide, you see one of our staff members preparing specimens in a biosafety cabinet. And on the top of the slide, the right top of the slide, you see our hunting trophy wall of our goggles. Okay, so this slide here shows you the early COVID-19 timeline in Singapore. So on the left half of the slide, you see the timeline until 7th of February. Yeah, it starts on the lower left end with a few Chinese nationals visiting Singapore from Wuhan and starting the few cases. On the 23rd January, as I said, Singapore had its first case from a traveler from Wuhan. Then the first Singaporean under the confirmed cases happened on January the 31st, but this was a Singaporean returning from Wuhan. Then, if you look further, on February the 1st, there was the first locally transmitted cluster, meaning the first few locally transmitted cases. And on the next day, a 6-month-old baby was admitted to our hospital who had been part of that cluster and also infected. Subsequently, on the 7th of February, Singapore raised its disease outbreak alert level, which is called DORSCON, to orange. And on the right part of the slide, you see a subsequent timeline until 2nd of April. So again, it started with a first wave of imported cases from China. Then was a second wave of early local clusters and local transmission. Then there was a third wave of returning Singaporeans and Singapore residents coming back from overseas. And so the outbreak developed. Many people from different places will ask us what are the PPE measures at the hospital, personal protective equipment, obviously. And it was designed, in my opinion, quite well. We had triage counters, and at the counter staff, they needed to wear a surgical mask, and the clinical staff at the triage counter an N95 mask. But in patient care, it was distinguished between suspected or confirmed patients and non-suspect patient. And the staff looking after suspected or confirmed patients needed to wear N95 masks and goggles for extended use, and gowns and gloves for single use. And for the non-suspect patients, they only needed to wear surgical masks. However, for aerosol generating procedures such as suctioning or taking specimens, for the suspected or confirmed patients, they needed to wear N95 masks and goggles and gowns and gloves, all for single use per patient. And for other patients, all aerosol generated procedures needed to undergo N95 masks and goggles for extended use and gowns and gloves for single use. Similar measures were also taken for environmental cleaning, and all admin staff and patients and visitors had to wear surgical masks or cloth masks. Then some other measures were taken during the DORSCON orange phase in Singapore. For example, hospital staff needed to take the temperature 2 times daily and record on the staff intranet. And anyone of hospital staff who has even mild flu-like symptoms, sore throat, runny nose, must report to the staff clinic, get COVID tested and placed on 5 days of mandatory home quarantine. And if someone is found outside their house, it's $10,000 fine. All leave for hospital staff was disallowed, and staff arriving from other countries must serve 14 days of stay-home notice. Meetings, education and research was restricted. Most meetings and education were done via teleconferencing, and research was restricted. Visitors had to register for access at the hospital, and only 1 visitor per patient was allowed. And similarly, elective procedures and clinic visits were restricted. Here on this slide, I'm showing Singapore's patient categories and indications for testing. There are 3 different timelines, but for the sake of simplicity, let us focus on the last timeline on the right side of the slide, which is from 8th of May and currently still in place. So one testing category was meet Ministry of Health suspect case definition. Then you had to be tested, of course. The second criteria was other clinical reasons for example, fever, acute respiratory infections, or atypical symptoms. The third reason for testing was surveillance of a confirmed case. And the fourth reason was other reasons not clinically indicated, for example, a patient's request. And the number 4 was then chargeable to the patient, so the patient had to pay. We also made, during the pandemic, quite naturally, some research findings, and we published this in some of the journals. For example, this one shows you the case of a paucisymptomatic child. This was the 6-month-old infant, also mentioned on the earlier slide, and this infant was just admitted for testing and isolation because the mother was infected. The baby remained totally asymptomatic except mild fever of 38.5 on 1 single day, but it had a low CT value on the nasopharyngeal swab, and that CT value corresponded to about 6 billion virus copies per nasopharyngeal swab. The baby's nasopharyngeal swab samples remained positive up to 16 days. And I would suggest, even though this is untested, that a child with such a high virus load must be quite highly infectious. And in our lab's lowest recorded CT value on the PCR was 9.7, and that was in an adult, and this corresponds to about 100 billion virus particles per nasopharyngeal swab. So this next article that we published shows you the environment of the said infected child. As I said, the child was very poorly symptomatic, and in the isolation room we tested the bed, the cot rail and the table, which were positive. You see the plus signs on the drawing here. Also the healthcare worker's face shield, N95 mask and gown, which luckily remained negative. So our conclusion from that was that infected well infants with no obvious respiratory symptoms can still easily contaminate the environment. Another little publication that we did was we compared buccal swabs versus nasopharyngeal swabs, and the rationale is that buccal swabs in little children are much easier and much less annoying to obtain from children than nasopharyngeal swab. However, to cut it short, and I'm not going to go into big details, it turned out that buccal swabs were very disappointing, and so they ended up being a factor of 1,000 analytically less sensitive than nasopharyngeal swab, and we concluded that they are not a good specimen to take. Let's talk a bit about Singapore's public health measures. Singapore has been called exemplary in contact tracing, isolating and identifying clusters. And so here on the left side of the slide, you see classical contact tracing with a positive virus case. Then that case is interviewed by public health workers, and then contacts identified and then quarantined appropriately. Singapore has now increasingly adopted technology for that purpose. So for example, there is a smartphone app, Traced Together. And effectively what happens is when A and B meet, their phones exchange a key code. And when A later becomes infected, the status on the phone is updated, and then anonymized data are transmitted in the sense that the person B, who has been close to person A, might have been exposed and might need to be investigated. And a similar application exists by way of a token, the so-called Trace Together token on the right side of the slide, which is similar to the smartphone app, except that it is a token that can be carried around by a patient or by someone from the general public. Needless to say, the whole pandemic also attracted a number of coronavirus jokes. On the left, we have a joke that the Mexican beer brand was renamed in Ebola in order not to be associated with the coronavirus. And then in the middle of the slide is a German Chancellor Merkel, who looks very visibly aged, and she says, "It is over, you may come out again." And then underneath her is a Valentine's Day gift with a mask and hand sanitizer, etc. And on the right side of the slide, bottom, is a cruise ship, and the cruise ship sails by a stranded person on a lone island. And instead of wanting to be picked up by the cruise ship, the person actually hides from the cruise ship. Okay, what happened subsequently was a turn of events in Singapore. So from the story so far, you would have gathered that Singapore did reasonably well, but here there was a turn of events. And that was in late March, early April, where cases were reasonably under control with aggressive isolation and contact tracing efforts. At that time, shops and schools were still open and the public life was largely unaffected. But then what happened was cases emerged at foreign worker dormitories starting on 30th of March. And the background to this is that Singapore has about 300,000 low-income foreign workers, mostly in the construction business, for example, from countries like India, Bangladesh, Myanmar. And these workers are housed in relatively cramped conditions in dormitories with about up to 15 to 20 people in one bedroom. And so the virus got a foothold, spread like wildfire in these dormitories, and subsequently all of these dormitories were declared quarantine areas and were surrounded by the armed forces. And the Singapore government devised a comprehensive testing and relocation strategy of these workers to the so-called government quarantine facilities, or GQFs. So this slide here shows you the subsequent timeline in Singapore. On the left side of the slide is the timeline until the 17th of April. So what you see here is three types of cases. On the top of that little graph, you see imported cases, which peaked in March, but we have already mentioned that. In the middle of the graph, you see the community cases, and then on the bottom, you see the dormitory residents who basically spiked at the beginning of April. And then subsequently, on 7th April, the Singapore government declared a measure called the circuit breaker, meaning it was a lockdown similar to the lockdowns that were also imposed in many other countries. And so these infections in the dormitory workers then constituted the so-called fourth wave, which is continuing up until now. And you see on the right side of the slide the timeline until 11th July, and these cases continue largely in three distinct epidemiological curves. So what we had to do in the laboratory is we had to cope with increased testing demands. And so to cope with the increased test demands, Ministry of Health set up the Testing Operations Center, and that center would allocate the testing needs from the dorms and government quarantine facilities across all public and private labs. And what we found in our lab is that testing in high prevalence settings is quite difficult. What we got is many samples with low level or borderline amplification curves, which presumably corresponded to different stages of infections. And we needed to do extensive retesting and confirmatory testing for these. So if you look on the bottom of the slides, you have a set of typical amplification curves. And the earlier the curve rises, the more positive is the sample, so to speak. And you see the positive control marked here. But then when you look to the left of that same graph, to the right of that same graph, you see a lot of amplification curves that are just rising above the background. And on the right side of the slide, I have highlighted some of these. And when you look at these amplification curves, you ask yourself, what are these? Are they actually positive or are they negative? And what we do in our lab, we need to rerun all of these specimens on a different PCR assay with a different primer system so that effectively these cases could be confirmed or refuted. Singapore also, this is the next slide, Singapore also instituted some measures for the general public. So before April, the situation was relatively normal and the public life was not much affected. There was some panic buying after 7th of February, but that quickly subsided. But then from 7th April, the circuit breaker came into action. There were school closures, only essential businesses were open, and public mask wearing, cloth masks or surgical masks was mandated. Restaurants could only serve takeouts. Gatherings were restricted, so friends couldn't visit each other. Only within families could be together. No gyms were opened, no religious gatherings, travel was largely restricted, etc. By and large, the public accepted these measures well, but of course there was some ensuing economic consequences and hardship. And on the right side of the slide, you see an access control to various public places and shopping centers. So basically, customers going into a shopping center had to register themselves and log themselves in. After the 2nd of June, there was a reopening in phases, which is termed safe reopening, safe transition, and safe nation. And so we're currently within this gradual or slow reopening phase of Singapore. So in this last slide, I would like to offer you some conclusions and an outlook. So in my opinion, Singapore generally managed the crisis quite well. It benefited from preparedness. As of 2nd July, there were 44,000 cases. Meanwhile, it's about 46,000 cases and 26 deaths, which is a remarkably low death rate. And of course, needless to say that the outbreak in the foreign workers' dormitories constituted a lapse of attention to this vulnerable part of the population. And this resulted in rapid spread, and this now constitutes the majority of Singapore's cases. On the ground, I would say, even though some of what I said sounded quite smooth, I would say the work on the ground for us in the lab was still quite challenging. And I'm assuming, being a lab person, that the work at the clinical interface is even more challenging. Luckily, so far, we've had no major PPE shortages. They were stockpiled before the pandemic, and I'm being told that Singapore, with a population of 6.6 million, had a stockpile of 19 million N95 masks. We experienced some temporary lab reagent shortages, but they were then subsequently overcome with centralized procurement and with purchasing of alternatives. I would also like to point out the capacity building and maintaining to cope with a pandemic. The completion of the NCID, which was long planned in 2019, was very fortuitous. It was obviously accidental to be just in 2019, but it worked out very well. Our lab at the hospital, at KK Hospital, was under-resourced and understaffed at the beginning of the outbreak. This was improved during the outbreak, and luckily we received some help from our hospital leadership, which we can really be thankful for. Furthermore, I would say the capacity to do lab-developed tests, so-called LDTs, saved us in the lab, because LDTs, what they can do is they can make you ramp up your testing capacity very, very quickly for any novel virus or pathogen. So I would say that maintaining clinical lab capacity, staffing and skill sets is essential for an outbreak response. For the future, I would say I don't know, and for me it is unclear how the pandemic will progress. I personally think it is unlikely to have any relief before the vaccine availability, perhaps in 2021. And at that time, I would thank everyone for your attention. We are heading into the morning break, and I would like to hand over to Kevin Kavanagh for further moderation. Thank you again.